Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our Geriatric Medicine Pearl Notes. Pearl Notes are the most important components of our Passmedicine Pearl course. They are the cornerstone of Passmedicine, and it's mandatory for the MRCP candidates to master them completely from the beginning to the end. It's highly recommended you should start by watching the video lecture first, then go through the lecture notes. For revision purpose, you may go through the notes specially before the exam. And make sure you have revised the Pearl notes as many times until you can recall them even when you are sleeping or dreaming. Constipation can cause delirium in the elderly. New surroundings can cause delirium in cognitively impaired patients, especially in Alzheimer's dementia. Delirium is also known as the acute confusional state or acute organic brain syndrome. The precipitating events for acute confusional state or delirium is often multifactorial. But for the exam purpose, you must remember three conditions. Number 1, constipation. Number 2, change of environment or new surroundings. And number 3, infections, particularly the urinary tract infections. Haloperidol is the default first-line choice of treatment in a patient with delirium or acute confusional state, provided that there is no contraindication. The two typical contraindications are in a patient associated with the features of Parkinsonism or in a palliative care patient during the last days of life. Haloperidol is contraindicated in patients with Parkinson's disease. Mode of action of haloperidol is the dopamine antagonist. Haloperidol is the first generation typical antipsychotics which blocks dopamine D2 receptor in the prefrontal cortex. So any drugs that causes dopamine antagonism must be avoided in a patient with Parkinson's disease. Constipation can cause delirium in the elderly. New surroundings can cause delirium in cognitively impaired patients. Constipation, new surroundings or change of environment, infections, particularly the urinary tract infections. Haloperidol is contraindicated in patients with Parkinson's disease. If a patient with Parkinson's disease comes up with the features of agitation, choice of treatment should be low-dose short-acting benzodiazepine like the lorazepam or the midazolam. Remember this very carefully, low-dose short-acting benzodiazepine, not the long-acting benzodiazepine like the diazepam. And if a patient with Parkinson's disease comes up with the features of visual hallucination, meaning underlying diagnosis of Lewy body dementia, then choice of treatment should be the antipsychotic drugs like the quetiapine or the clozapine. If both quetiapine and clozapine are in the option, you should choose the quetiapine due to the potential toxicity of treatment of the clozapine, like the agranulocytosis, neutropenia, myocarditis, or the prolongation of the QT interval. They are related to the clozapine treatment. Acetylcholinesterase inhibitors such as donepezil are the first line for mild to moderate Alzheimer's disease. Mild to moderate Alzheimer's disease can be assessed using the MMSE score. Roughly, the score for mild to moderate cognitive impairment or mild to moderate Alzheimer's disease should be in between 10 to 20. And when the score is less than 10, this is the severe cognitive impairment. So when the MMSE score is in between 10 to 20, we can start the treatment with the acetylcholinesterase inhibitors like the donepezil or rivastigmine or galantamine. Donepezil can cause the insomnia. Sleep disorders are a common side effect of donepezil, and the drug memantine usually leads to sleepiness or hypersomnolence. So donepezil insomnia, memantine hypersomnolence. Donepezil is generally avoided relative contraindication in patients with bradycardia and is used with cautions in other cardiac abnormalities. Donepezil may cause bradycardia and the atrioventricular AV nodal block. Cholinesterase inhibitor groups of drug has got their phagotonic effects. Due to the phagotonic effect, the cholinesterase inhibitors usually leads to the increased vagal tone leading to bradycardia and the heart block. So if cholinesterase inhibitors are used in a patient with resting bradycardia or in a patient with first degree heart block, there is significant chance of precipitation of the complete heart block. So acetylcholinesterase inhibitors groups of drugs should be avoided in a patient with bradycardia or in a patient with first degree heart block or complete heart block, even if the patient has got the mild to moderate Alzheimer's disease. Also in patients with sick sinus syndrome or in a patient with a group of heart rhythm disorder, the sinus node doesn't work properly, so this would ultimately lead to severe symptomatic bradycardia or even sinus arrest. Cholinesterase inhibitors medication should also be contraindicated or should be started with caution in patients with conduction abnormalities or to those patients who are already taking the negatively chronotropic medications. Most commonly used negatively chronotropic medications are the beta blockers or digoxin or the rate limiting calcium channel blockers like the diltiazem or the verapamil. So let me make it simplify for you. Mild to moderate Alzheimer's disease without any contraindication. Start treatment with the acetylcholinesterase inhibitors. Mild to moderate Alzheimer's disease with contraindication. Avoid the acetylcholinesterase inhibitors and go with the memantine. Donepezil can cause insomnia and memantine causes the hypersomnolence. Donepezil is generally avoided relative contraindication in patients with bradycardia and is used with caution in other cardiac abnormalities. Donepezil, rivastigmine, galantamine, they are the cholinesterase inhibitors. These groups of cholinesterase inhibitors are the default first-line choice of treatment for mild to moderate dementia, provided that there is no contraindication. Memantine is the NMDA receptor antagonist. This is usually indicated in severe dementia or severe Alzheimer's disease, or in case of mild to moderate dementia with contraindication to the cholinesterase inhibitors. So the acetylcholinesterase inhibitors like donepezil, galantamine, or rivastigmine are the first line for the management of mild to moderate Alzheimer's dementia, and memantine is used as the first line in severe Alzheimer's dementia, or as a second line or add-on treatment for mild to moderate Alzheimer's dementia. So let me make it simplify for you. Memantine is recommended for severe Alzheimer's disease or for patients with moderate disease who can't tolerate or haven't responded to cholinesterase inhibitors. So indications of memantine would be monotherapy in severe Alzheimer's disease, MMSE score less than or equal to 9, moderate Alzheimer's disease who are intolerant or have got contraindication to acetylcholinesterase inhibitor, or as an add-on drug to acetylcholinesterase inhibitors for patients with moderate or severe Alzheimer's dementia. Antipsychotics are associated with a significant increase in mortality in dementia patients. Antipsychotics should only be used for patients who are at a very high risk of harming themselves, or those who have got the severe agitation, hallucination, or delusion causing the significant distress. Under normal condition, we should always avoid the antipsychotics in a patient with dementia. donepezil, galantamine, and rifostacin. They are the acetylcholinesterase inhibitors. These groups of acetylcholinesterase inhibitors increase the amount of acetylcholine inhibitors in the synaptic cleft, leading to increased effects at the postsynaptic receptor. Patients with Alzheimer's disease have reduced production of choline acetyltransferase, which will ultimately lead to decrease in acetylcholine synthesis and impaired cortical cholinergic functioning. For this reason, the cholinesterase inhibitor will lead to improvement of cognitive function and improvement in activities of daily living in a patient with mild to moderate Alzheimer's disease. So, acetylcholinesterase inhibitor are indicated in mild to moderate Alzheimer's disease. Acetylcholinesterase inhibitor will have no role in advanced Alzheimer's disease or severe Alzheimer's disease. In advanced or severe cases, we need to go for the memantine. Memantine and ketamine, they are the NMDA receptor blockers. NMDA means N-methyl D-aspartate. This memantine is used in case of advanced or severe dementia. And ketamine is the dissociative anesthetic agent. Memantine and ketamine also blocks the glutamate transmission in the brain. And glutamate is the excitatory neurotransmitter. Antipsychotics are associated with a significant increase in mortality in dementia patients. Delirium involves an impairment of consciousness level and often involves psychotic symptoms. Impairment of consciousness suggests delirium over dementia. Acute confusion with impaired consciousness with a history of a very short duration is highly suggestive of the delirium. And this impairment of conscious level or impairment of consciousness is the hallmark of delirium. And this impairment of consciousness or conscious level would be evidenced by reduced score in the GCS, Glasgow Coma Scale. Delirium involves an impairment of conscious level and often involves psychotic symptoms. Fluctuation of symptoms helps to differentiate delirium from the dementia. Fluctuation of symptoms is highly suggestive of the delirium, acute confusional state. Fluctuation means the symptoms will fluctuate throughout the day and from one day to the next day. And the symptoms would be manifested over a very short period of time. And the symptoms may be of disordered thinking, labile mode, reversal of the sleep-wake cycle, inattention, disorientation, or the memory impairment. Tricyclic antidepressant like the amitriptyline is often associated with the cognitive impairment when they are used in the elderly patient. So we should always avoid the tricyclic antidepressant in elderly patients with dementia unless they are absolutely indicated. Neuroleptics like the haloperidol should be avoided in Lewy body dementia or in a patient with Parkinson's disease. Patients with Lewy body dementia are extremely sensitive to the neuroleptic drugs like the haloperidol. They are also the antipsychotic drugs. Exposure to neuroleptics in a patient with Lewy body dementia will ultimately lead to severe exacerbation of their Parkinsonian symptoms, leading to irreversible Parkinsonism. In the exam, usually you will get a history of a patient who has deteriorated following the introduction of an antipsychotic agent or an neuroleptic agent like the haloperidol. Visual hallucination with dementia in a patient with Parkinson's disease is highly suggestive of the Lewy body dementia. Lewy body dementia is usually diagnosed clinically, but in the exam, if they ask regarding the investigation of choice, then SPECT scan is the investigation of choice in case of Lewy body dementia. SPECT means single photon emission computed tomography. This is also known as the DAT scan. This SPECT scan is highly sensitive and highly specific for the diagnosis of the Lewy body dementia. It has got around 90% sensitivity and 100% specificity with regards to the Lewy body dementia diagnosis. Cardinal features of Lewy body dementia would be signs of Parkinsonism, visual hallucination, dementia in the form of memory impairment or cognitive impairment, and this cognitive impairment is often progressive and associated with fluctuating confusion or cognition. So, patient presenting with the triad of signs of Parkinsonism, visual hallucination, progressive cognitive impairment associated with fluctuating confusion or cognition is highly suspicious of the Lewy body dementia. And the pronounced sensitivity to neuroleptics like haloperidol is one of the cardinal features of Lewy body dementia. This sensitivity to neuroleptics can manifest as a severe worsening of the motor symptoms or the development of the neuroleptic malignant syndrome. Acetylcholinesterase inhibitors like the donepezil, rivastigmine, or galantamine are the choice of treatment for the management of Lewy body dementia. Acetylcholinesterase inhibitors like donepezil or rivastigmine are the most effective treatment in Lewy body dementia and can treat both cognitive and the motor symptoms. Visual hallucination is the cardinal features of Lewy body dementia, and the worsening of the visual hallucination is likely to be driven by an increase in the dopamine in the mesolimbic pathway. So the visual hallucination in Lewy body dementia is directly related to the levodopa and the carbidopa. The more will be the level of levodopa and carbidopa, the more will have the higher chance of worsening visual hallucination. So for the management of visual hallucination in a patient with Lewy body dementia, we should go for the reduction in the dose of carbidopa and levodopa. And after reduction of the level of levodopa and carbidopa, we should start the acetylcholinesterase inhibitor like either donepezil or rivastigmine or the galantamine. And one thing you should remember very carefully, you should go for the decreasing the dose of carbidopa levodopa. You should never go for the abrupt cessation or abrupt discontinuation of the carbidopa or levodopa. Abrupt cessation will ultimately lead to the Parkinsonism hyperpyrexia syndrome. The clinical picture of this syndrome is somewhat similar to that of the neuroleptic malignant syndrome. So for the management of Lewy body dementia, we should at first reduce the dose of levodopa carbidopa followed by introduction of the acetylcholinesterase inhibitors. Lewy body dementia typically presents with fluctuating cognition in contrast to other forms of dementia, and exacerbating factors are the urinary tract infections and the amitriptyline medications. Typical antipsychotics should be avoided in delirious patients with a background of Parkinson's disease. Visual hallucination with dementia in a patient with Parkinson's disease is highly suggestive of the Lewy body dementia. Neuroimaging is required to diagnose the dementia. Structural imaging in the form of CT or MRI head is recommended in the investigation of dementia, both to exclude reversible causes of cognitive decline like the NPAs, normal pressure hydrocephalus or subdural hemorrhage, and also to assist with dementia subtype diagnosis. So neuroimaging in the form of CT or MRI is one of the preconditions for the diagnosis of the dementia. Along with the diagnosis, it will also assist with the subtype diagnosis. MRI features suggestive of a diagnosis of Alzheimer's disease include mesial temporal lobe atrophy and the temporoparietal cortical atrophy. Global or diffuse cerebral atrophy is the features of Alzheimer's disease. but in most of the cases of Alzheimer's disease, usually the temporal lobe atrophy or temporal parietal cortical atrophy is more pronounced. Stepwise deterioration in cognitive function is highly suggestive of the vascular dementia. And the presence of multiple vascular risk factors for the cerebrovascular disease like hypertension, smoking, or stroke is one of the preconditions for the diagnosis of the vascular dementia. If vascular risk factors are absent, then vascular dementia is unlikely. And this stepwise deterioration in cognitive function in a patient with vascular dementia is caused by ischemia or hemorrhage secondary to cerebrovascular disease. Stepwise deterioration in cognitive function, think of the vascular dementia. Waterloo score is used to identify or to assess patients who are at a risk of development of the pressure sores or the pressure ulcers. This Waterloo score was developed by Judy Waterloo. For the assessment of Waterloo score, usually several factors are taken into consideration, like the BMI, nutritional status, skin type, mobility, continence, and other special risk factors such as the tissue malnutrition and neurological deficit. A higher score usually indicates the greater risk of developing the pressure sores. In case of Waterloo scoring, the potential score usually ranges from 1 to 64. A score greater than 10 is indicative of increased risk of pressure sore development. Score greater than 15 is suggestive of high risk, and score greater than 20 is indicative of the very high risk. Assessment of pressure sores or pressure ulcers, go for the Waterloo score assessment. Mini mental state examination (MMSE) is also known as the Falstein test. MMSE is a 30-point questionnaire for cognitive impairment assessment. Since this is a 30-point questionnaire, so the high score or the total score should be equivalent to 30. So now let's analyze the score with respect to the cognition status. So when the score is greater or equal to 24 out of 30, this indicates the normal cognition. 19 to 23, mild cognitive impairment. 10 to 18, moderate cognitive impairment. Less than or equal to 9, severe cognitive impairment. For simplification, you can remember less than 10, severe cognitive impairment. In between 10 to 20, mild to moderate cognitive impairment. And whenever the score is less than 10, meaning severe cognitive impairment, choice of treatment may maintain in a patient with Alzheimer's dementia. And when the score is in between 10 to 20, meaning mild to moderate cognitive impairment or mild to moderate dementia, go for the acetylcholinesterase inhibitors like the donepezil, rivastigmine, or galantamine, provided that there is no contraindication. And the score greater or equal to 25 is suggestive of the normal cognition. Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our Geriatric Medicine Key Concepts. And the key concepts are directly adapted from the Passmedicine online question bank. Acute confusional state. If treating the underlying cause and the environmental modification not working, then haloperidol is sometimes used. Acute confusional state, this is also known as the delirium. Haloperidol is the default first-line choice of treatment in all acute confusional state or delirium, except in a patient with underlying Parkinsonism. At first, we should offer the oral haloperidol. If the patient refuses to take the oral medication, in that case, we can switch on to the intramuscular haloperidol. Antipsychotics are associated with a significant increase in mortality in the dementia patients. Antipsychotics should never be used in a dementia patient or in an elderly patient unless they are absolutely indicated. Antipsychotics should only be used in a patient with dementia if they have the significant risk of self-harm or if there is presence of severe agitation, hallucination or delusion affecting their qualities of life. Constipation can cause delirium in the elderly. Delirium is often multifactorial, and constipation, change of environment or new surroundings, and infections, particularly the urinary tract infections, are the common precipitating factors. Delirium involves an impairment of conscious level and often involves psychotic symptoms. Impairment of conscious level is a classical feature of delirium, and impairment of consciousness level would be evidenced by low GCS. Donepezil is an acetylcholinesterase inhibitor. Donepezil, rivastigmine, and galantamine, all of them are the acetylcholinesterase inhibitor. They are the default first-line choice of treatment in mild to moderate dementia, provided that there is no contraindication. Donepezil can cause insomnia. Sleep disorders are a common side effect of donepezil. Donepezil is generally avoided relative contraindication in patients with bradycardia and is used with caution in other cardiac abnormalities. So whenever there is contraindication, we should avoid the acetylcholinesterase inhibitor and we should go for the memantine. Fluctuation of symptoms help to differentiate delirium versus dementia. Fluctuation of symptoms are also the classical features of delirium. So impairment of conscious level as well as fluctuation of symptoms, both of them are the cardinal features of delirium. Frontotemporal dementia presents with social disinhibition and often has a family history. Social disinhibition in the form of bizarre pattern of behavior or sexual disinhibition is one of the classical findings of FTD, frontotemporal dementia or frontotemporal lobar dementia. Previously, they were known as the Pick's disease. Haloperidol is contraindicated in patients with Parkinson's disease. Haloperidol has got their dopamine antagonizing property, which will ultimately causes worsening of the motor features of Parkinson's disease. Memantine is an NMDA receptor blocker or antagonist. Neuroimaging is required to diagnose the dementia. Neuroimaging in the form of CT or MRI is one of the preconditions for the diagnosis of dementia. New surroundings can cause delirium in cognitively impaired patients. NICE guidelines don't support the use of memantine in mild dementia. So memantine shouldn't be used in mild dementia unless there is contraindication to the acetylcholinesterase inhibitor, and the cholinesterase inhibitor shouldn't be used in case of advanced or severe dementia. Memantine is usually used as the first line in case of severe dementia or as a part of add-on therapy in case of moderate dementia, provided that the patient does not respond well to the acetylcholinesterase inhibitor, or it can be used when there is contraindication to the cholinesterase inhibitor. Stepwise deterioration in cognitive function, think of the vascular dementia. Tight control of vascular risk factors rather than anti-dementia medication is recommended by NICE in vascular dementia. Presence of vascular risk factor is one of the preconditions for the diagnosis of vascular dementia, and also as a part of management protocol, more priority should be given for the prophylactic management. Typical antipsychotics should be avoided in delirious patients with a background of Parkinson's disease. In a patient with underlying Parkinson's disease presenting with delirium, we should go for the atypical antipsychotics like the quetiapine. Visual hallucination with dementia in a patient with underlying Parkinson's disease is highly suggestive of the Lewy body dementia. Lewy body dementia is one of the Parkinson plus syndrome. Waterloo score is used to identify patient as a risk of pressure source. The more will be the Waterloo score, the higher will have the patient's chance of developing pressure sores or pressure ulcers. Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our Geriatric Medicine textbook overview discussion. Acute confusional state, also known as delirium. Acute confusional state is also known as delirium or acute organic brain syndrome. It usually affects 30% of the elderly patients admitted to the hospital. Predisposing factors usually include age of the patient greater than 65 years, background of dementia, significant injury like the hip fracture, frailty or multimorbidity, as well as the polypharmacy. As a part of predisposing factors for delirium, you must remember older age of onset and prior history of the dementia. The precipitating events are often multifactorial and may include infection, particularly urinary tract infections, metabolic events like hypercalcemia, hypoglycemia, hyperglycemia, as well as the dehydration, change of environment, meaning new surroundings, any significant cardiovascular, respiratory, neurological, or endocrine condition, severe pain, alcohol withdrawal, as well as the constipation. For the exam purpose, as a part of precipitating events, you must remember three conditions. Number one, infection, particularly the urinary tract infections, change of environment or new surroundings, and the constipation. Features of delirium: a wide variety of presentations. Memory disturbances, loss of short term compared to the long term, may be very agitated or withdrawn, disorientation, mood change, visual hallucinations, disturbed sleep cycle, poor attention. Visual hallucinations are more commonly seen in a patient with delirium if the patient has the underlying Parkinson's disease, particularly the Lewy body dementia. Management of delirium or acute confusional state. Treatment of the underlying cause. Modification of the environment. Since delirium has got multifactorial etiology, so at first we should go for management of the underlying cause or underlying condition, followed by modification of the environment, since the new surroundings or change of environment is also one of the precipitating factors. After that, we should switch on to the pharmacological therapy. Haloperidol 0.5 mg as a part of first-line sedative is often indicated in a patient with delirium. At first, we should offer the oral haloperidol. If the patient refuses to take the oral medication, then intramuscular haloperidol is a potential alternative option. Alternative to haloperidol, we can also go for the olanzapine. Olanzapine is an atypical antipsychotic drug. Management can be challenging in patients with Parkinson's disease as antipsychotics can often worsen the Parkinsonian symptoms. Haloperidol as well as the typical antipsychotics have got their dopamine antagonizing properties. which ultimately leads to worsening of the motor features of Parkinson's disease. So, if a patient with delirium has got underlying Parkinson's disease, then we can go for haloperidol or other typical antipsychotics. Careful reduction of the Parkinson medication may be helpful. So, as a part of initial step, we should go for dose reduction of carbidopa and the levodopa. After that, if the symptoms require urgent treatment, then we should switch on to the atypical antipsychotics. We have the potential options like quetiapine or clozapine. If both of them are in the option, then we should go for the quetiapine. Alzheimer's disease pathophysiology. Alzheimer's disease is a progressive degenerative disease of the brain, accounting for the majority of the dementia seen in the UK. Alzheimer's disease is the most common cause of dementia. Risk factors usually include increasing age, family history of Alzheimer's disease. 5% of cases are inherited as an autosomal dominant trait. There is often association with the apoprotein E allele E4, which encodes a cholesterol transport protein, Caucasian ethnicity, Down syndrome. Pathological changes of Alzheimer's disease. Patient will have widespread cerebral atrophy, also known as the diffuse cerebral atrophy, particularly involving the cortex and the hippocampus. So patient will have the diffuse cerebral atrophy, which should be more predominant in the cortex and the hippocampus. The microscopic features usually include deposition of type A beta amyloid protein as well as the neurofibrillary tangles. And this neurofibrillary tangles is caused by abnormal aggregation of the tau protein. And this tau protein is the pathognomonic features of Alzheimer's disease. Neurofibrillary tangles, paired helical filaments, are partly made from a protein called tau. So Alzheimer's disease is equal to tau protein. Alzheimer's disease management. Pharmacological management of Alzheimer's disease. The three acetylcholinesterase inhibitors, donepezil galantamine, rivastigmine, as an options for managing mild to moderate Alzheimer's disease. So the cholinesterase inhibitors are the default first-line choice of treatment for mild to moderate Alzheimer's disease, provided that the patient doesn't have any contraindication. And the mild to moderate Alzheimer's disease means the MMSE score roughly should be in between 10 to 20. Memantine, an NMDA receptor antagonist, is in simple terms the second-line treatment for Alzheimer's. NICE recommend it is used in the following situation reserved for patients with moderate Alzheimer's who are intolerant of or have a contraindication to acetylcholinesterase inhibitors, as an add-on drug to acetylcholinesterase inhibitors for patients with moderate or severe Alzheimer's, monotherapy in severe Alzheimer's. Managing of non-cognitive symptoms. NICE does not recommend antidepressant for mild to moderate depression in patients with dementia. Antipsychotics should only be used for patients at risk of harming themselves or others, or when the agitation, hallucinations, or delusions are causing them severe distress. So we should always avoid the antipsychotics unless they are absolutely indicated. And the antidepressants, particularly the tricyclic antidepressants, are often associated with increased mortality. So we should always try to avoid the tricyclic antidepressant in a patient with dementia. Donepezil is the acetylcholinesterase inhibitor, first line choice of drug for mild to moderate Alzheimer's disease. Donepezil is relatively contraindicated in patients with bradycardia. Adverse effects include insomnia. Delirium versus dementia. Factors favoring delirium over dementia: acute onset, impairment of consciousness, fluctuation of symptoms, worse at night, periods of normality, abnormal perception like illusions and hallucinations, agitation, fear, delusions. For the exam purpose, you must remember the first three factors, and these three factors are highly suggestive of delirium. So, acute onset, impairment of consciousness, fluctuations of symptoms. These three are the cardinal features of delirium. Dementia. The most common cause of dementia in the UK is Alzheimer's disease, followed by vascular and Lewy body dementia. So, Alzheimer's disease is the most common cause of dementia. Vascular dementia and Lewy body dementia are the second most common cause. Frontotemporal dementia or frontotemporal lobar degeneration (FTLD) is the third most common cause of dementia, and these conditions often coexist. Diagnosis can be difficult and is often delayed, and often we go for the mini mental state examination (MMSE) to go for the gradings of dementia. MMSE is also known as the Falstein test. A MMSE score of 24 or less out of 30 suggests the dementia. So the total score would be 30, and in a normal individual the score is always greater than 24, and if this is less than 24, this indicates the dementia. In between 10 to 24, this is usually regarded as mild to moderate dementia, and when the score is less than 10, this is regarded as severe dementia. Management of dementia. In primary care, a blood screen is usually sent to exclude the reversible causes like the hypothyroidism. NICE recommend the following tests: full blood count, urea and electrolyte, liver function test, calcium, glucose, ESR or CRP, thyroid function test, vitamin B12 and folate levels. So whenever a patient presents with a clinical picture similar to that of dementia, as a part of routine investigation, we must go through this test. Patients are now commonly referred to old age psychiatrists, sometimes working in the memory clinics. In secondary care, neuroimaging is performed to exclude other reversible conditions like the subdural hematoma or the normal pressure hydrocephalus, and helps provide information on etiology to guide prognosis and the management. So neuroimaging will have the two roles. Number one, to exclude the differentials, and number two, to aid for the subtype diagnosis of the dementia. Based on the NICE guidelines of 2011, structural imaging was said to be essential in the investigation of dementia. Structural imaging may be CT, structural imaging may be MRI, depending on the clinical picture. Dementia causes. Common causes usually include Alzheimer's disease, cerebrovascular disease like multi-infarct dementia. This multi-infarct dementia is also known as the vascular dementia, and the Lewy body dementia. So Alzheimer's disease is the most common cause. Multi-infarct dementia and Lewy body dementia are the second most common cause. Rarer causes, around 5% of cases: Huntington's, Creutzfeldt-Jacobs disease, Pick's disease, also known as the behavioral variant frontotemporal lobar degeneration, who is usually present with atrophy of frontal and temporal lobes. HIV, around 50% of the AIDS patient. Important differentials, potentially treatable: hypothyroidism, additions, B12, folate, thiamine deficiency, syphilis, brain tumor, normal pressure hydrocephalus, subdural hematoma, depression, chronic drug use like alcohol or barbiturates. So there is a long list of differentials, and they are the potentially treatable conditions. So we need to go for the laboratory investigation as well as the neuroimaging first. Frontotemporal lobar degeneration, FTLD. Frontotemporal lobar degeneration is the third most common type of cortical dementia after Alzheimer's and Lewy body dementia. There are three recognized types of FTLD. Number 1, frontotemporal dementia, also known as the Pick's disease. Number 2, progressive non-fluent aphasia, also known as the CPA, chronic progressive aphasia. Number 3, semantic dementia. Common features of frontotemporal lobar dementia: onset before 65 years, insidious onset, relatively preserved memory and visuospatial skills, personality changes, and social conduct problems. Behavioral variant frontotemporal dementia, previously known as Pick's disease, is the most common type and is characterized by personality change and impaired social conduct. Behavioral variant FTD is a common early onset dementia syndrome characterized by degeneration of the frontal and temporal lobes and manifest clinically as progressive deterioration in behavior or cognition associated with 6 clinically discriminating features. Disinhibition, meaning loss of manners, decorum, socially inappropriate behavior, especially the sexual disinhibition. Apathy or inertia, loss of sympathy or empathy, perseverative or compulsive behaviors like simple repetitive movements, ritualistic behaviors. Hyperorality, like oral exploration of objects, increased consumption of alcohol or cigarettes, altered food preferences. Hyperorality may also be expressed as a part of binge eating. Executive dysfunction with relative sparing of the memory and visuospatial functions. So the memory and visuospatial functions are relatively preserved. Memory difficulties tend to develop later in the disease course. A family history of dementia is present in up to 40% of cases, with an autosomal dominant component being present in 10%. Focal gyral atrophy with a knife blade appearance is characteristic of the Pick's disease. Macroscopic changes seen in Pick's disease include atrophy of the frontal and temporal lobes. Microscopic changes include peak bodies, gliosis, neurofibrillary tangles, and the senile plaques. So FTD or Pick's disease will have frontal and temporal lobe atrophy, and Alzheimer's disease will have atrophy of the parietal and the temporal lobes. And this frontal lobe involvement is the pathognomonic features of Pick's disease. Management: NICE do not recommend that acetylcholinesterase inhibitors or memantine are used in people with frontotemporal dementia. FTD is usually treated with the SSRI, paroxetine or the fluoxetine. The second variant, CPA, chronic progressive aphasia or progressive non-fluent aphasia or progressive non-fluent aphasia. So here the patient will have the non-fluent speech and the comprehension would be relatively preserved. And the third variant, semantic dementia. Here the patient will have fluent progressive aphasia. The speech is fluent but empty and conveys little meaning. So semantic dementia will have the fluent progressive aphasia and CPA will have the non-fluent speech. Lewy body dementia. The characteristic pathological feature of Lewy body dementia is alpha-synuclein cytoplasmic inclusions, also known as the Lewy bodies, in the substantia nigra, paralimbic and neocortical areas. The relationship between Parkinson's disease and Lewy body dementia is complicated, particularly as dementia is often seen in Parkinson's disease. Also, up to 40% of patients with Alzheimer's have the Lewy bodies. Features of Lewy body dementia. Lewy body dementia often has the three cardinal features. Number 1, progressive cognitive impairment. Number 2, Parkinsonism. Number 3, visual hallucinations. And this type of patients will also exhibit predominant sensitivity to the neuroleptic agents. Progressive cognitive impairment typically occurs before Parkinsonism, but usually both features occur within a year of each other. This is in contrast to Parkinson's disease, where the motor symptoms typically present at least 1 year before cognitive symptoms. Cognition may be fluctuating in contrast to other forms of dementia. Fluctuating cognition, this is the cardinal features of delirium or Lewy body dementia. Whenever there is fluctuating cognition, usually the dementia is unlikely. In contrast to Alzheimer's, early impairment in attention and executive function rather than just memory loss. With regards to the visual hallucination, other features such as delusions and non-visual hallucination may also be seen. Diagnosis is usually clinical. Single photon emission computed tomography SPECT is increasingly used. It is currently commercially known as a DAT scan. Dopaminergic iodine 123, radio label 2-carbomethoxy 3,4-iodophenyl N3-fluoropropyl, nortropin, in short 123 IFP-CIT is used as a radioisotope. The sensitivity of SPECT in diagnosing Lewy body dementia is around 90% with a specificity of 100%. Management of Lewy body dementia. Both acetylcholinesterase inhibitors, donepezil, rifostigmine, and memantine can be used as they are in Alzheimer's. Neuroleptics should be avoided in Lewy body dementia as patients are extremely sensitive and may develop irreversible Parkinsonism. The clinical presentation of irreversible Parkinsonism after exposure to neuroleptics usually are identical to the neuroleptic malignant syndrome. Questions may give a history of a patient who has deteriorated following the introduction of an antipsychotic agent. Pressure ulcers. Pressure ulcers typically develop over the bony prominences such as the sacrum or the heel. The following factors predispose to development of pressure ulcers: malnutrition, incontinence, lack of mobility, pain which usually leads to a reduction in mobility. The Waterloo score is widely used to screen for patients who are at a risk of developing pressure areas. It includes a number of factors including the body mass index, nutritional status, skin type, mobility, continence, and other spatial risks such as tissue malnutrition and neurological deficit. A higher score indicates a greater risk of developing pressure sores. Grading of pressure ulcers. The following is taken from European Pressure Ulcer Advisory Panel classification system. So the gradings of pressure ulcers are divided into 4 grades: grade 1, grade 2, grade 3 and grade 4. Grade 1 indicates non-blanchable erythema of the intact skin, discoloration of the skin, warmth, edema, induration or hardness may also be used as indicators, particularly on individuals with the darker skin. So patient will have the non-blanchable erythema or other features, but there will be no skin loss, whether partial or full thickness. Grade 2, partial thickness skin loss involving epidermis or dermis or both. The ulcer is superficial and presents clinically as an abrasion or blister. Grade 3, full thickness skin loss involving damage to or necrosis of the subcutaneous tissue that may extend down to but not through the underlying fascia. Grade 4, extensive destruction, tissue necrosis or damage to muscle, bone or supporting structures with or without full thickness skin loss. So grade 1, only non-blanchable erythema. Grade 2, partial thickness skin loss involving epidermis or dermis. Grade 3, full thickness skin loss, but it wouldn't reveal the underlying fascia. In case of grade 4, there is extensive destruction and it will ultimately reveal the underlying structures like the fascia or the neurovascular structures. Management of pressure ulcers. A moist wound environment encourages ulcer healing. Hydrocolloid dressings and hydrogels may help facilitate this. The use of soap should be discouraged to avoid drying of the wound. Consider referral to the tissue viability nurse. Surgical debridement may be beneficial for selected wounds. Vascular dementia. Vascular dementia is the second most common form of dementia after Alzheimer's disease. It isn't a single disease but a group of syndromes of cognitive impairment caused by different mechanisms causing ischemia or hemorrhage secondary to cerebrovascular disease. Vascular dementia has been increasingly recognized as the most severe form of spectrum of deficits, encompassed by the term vascular cognitive impairment (VCI). Early detection and an accurate diagnosis are important in the prevention of vascular dementia. The three main subtypes of vascular dementia. Stroke-related vascular dementia may be multi-infarct or single-infarct dementia. Subcortical vascular dementia caused by small vessel disease. Mixed dementia, the presence of both vascular disease and Alzheimer's disease. Multiple cerebrovascular risk factors are associated with vascular dementia, and these risk factors are also the precondition for the diagnosis of vascular dementia. If this type of cerebrovascular risk factors are absent, then the vascular dementia is unlikely. History of stroke or transient ischemic attack, atrial fibrillation, hypertension, diabetes mellitus, hyperlipidemia, smoking, obesity, coronary heart disease, a family history of stroke or cardiovascular. In your exam, they will always give the history of the risk factor like smoking or history of stroke or any types of coronary arterial disease. Risk factors are associated with vascular dementia, and these risk factors are also the precondition for the diagnosis of vascular dementia. If this type of cerebrovascular risk factors are absent, then the vascular dementia is unlikely. History of stroke or transient ischemic attack, atrial fibrillation, hyperlipidemia, smoking, obesity, coronary heart disease, a family history of stroke or cardiovascular. In your exam, they will always give the history of the risk factor like smoking or history of stroke or any types of coronary arterial disease. Rarely, vascular dementia can be inherited, as in the case of CADASIL, cerebral autosomal dominant arteriopathy with subcortical infarction, leukoencephalopathy. Patients with vascular dementia typically present with several months or several years of history of a sudden or stepwise deterioration of the cognitive function. This stepwise or gradual reduction in the cognitive function is also one of the hallmark of vascular dementia. For the diagnosis of vascular dementia, we need to take a comprehensive history and physical examination. After that, we should go for the cognitive impairment screening with the help of MMSE. And if we go for the MRI, it will show infarcts and extensive white matter changes. The Nance iron criteria is often used for the probable vascular dementia diagnosis. General management of vascular dementia. Tight control of vascular risk factor is the mainstay of the treatment. Remember, we should always give emphasis on the prophylactic management in case of vascular dementia.